Hello, everyone. My name is Jose Francisco, Project Manager at the IAS-USA. Today's webinar will be going over sleep disorders and sleep assessment in people with HIV. I'd like to welcome today's presenter, Dr. Anna Krieger from Weill Cornell Medicine. Welcome, Dr. Krieger.
Thank you. Thank you so much for having me. So today we're going to be speaking about sleep disorders and sleep assessment in people with HIV. And a lot of the things we'll discuss today will really be applicable as well to people, to the general population. So I hope that you'll be able to benefit from this session. So we're starting with some CME information. So just review the CME information in case you're interested in applying for credits. And this course is also being approved for CMEs and other points like MLC and nursing, pharmacotherapy, and pharmacy training hours. And we thank our supporters for making this program possible. And as we navigate to the webinar today, we are going to have some questions that will have a separate window that will come up with a poll question, and feel free to answer that. There's no problem if you don't know the answer. You could leave it blank or you could guess. And then it will be helpful, I think, for as many people as possible to answer the poll questions, because that will help us to enhance the discussion. And the responses will be displayed after the poll closes. We'll save all the questions towards the end. We'll open a Q&A at the end of the presentation. And we thank you all again for participating. So we start with the first question, I think more as a general information that can help all of us. How often do you as a practitioner screen patients with HIV for sleep disorders? Do you review the sleep at every visit or annually, or when prompted by patients, rarely or never? So we should see the poll popping up on your screen. All right, so if you answer that, excellent, very good. I think at every visit, we have a good percentage of people that are screening, so this is great. I hope everyone can see that result as well. So the next question, we'll go through our learning objectives. So hopefully through this session today, you have an ability to better describe sleep physiology and how to improve sleep health in patients with HIV and also patients in general, and identify common sleep disturbances and what are the tools used for the evaluation of sleep complaints. And as a third objective, we would like to see if we can improve your knowledge regarding the diagnostic and therapeutic approaches for managing sleep disorders. So we start with a pre-test question. So this is a 56-year-old patient that presents to discuss sleep initiation difficulties after testing positive for HIV. What would be your first line recommendation? Prescribe an antidepressant, refer to psychiatry, prescribe a non-benzodiazepinic, or discuss non-pharmacological approaches? Feel free to answer. And we're going to have the discussion towards the end. So submit your answer. Now we're going to go into the next pre-test question. The best initial step for treating obstructive sleep apnea would be to either prescribe a continuous positive airway pressure device, refer to an ENT surgeon, recommend an over-the-counter dental appliance, or review clinical factors and severity of the disease prior to making recommendations. You may answer now. Thank you. So again, we'll review that towards the end of the presentation. So now we'll start with some basic functions of sleep. And I think our goal today will be to discuss the ideas of how to improve this physiology of sleep. So understanding the function of sleep, which is a question that often our patients ask, can be very helpful. So from all the functions listed, which ones do you think are regulated by sleep? Hormonal function, immune function, mood regulation, lymphatic clearance, or all of the above? So you may answer, excellent, very good. So yes, basically everyone got it right. A few people also, focus on mood regulation. Yes, sleep serves several purposes, many more than we could ever even list here. But definitely it helps synchronize hormonal function, immune regulation, mood regulation along with that. And the lymphatic clearance is really a new function of sleep that we didn't even understand existed well before. So that's something very important in terms of clearance and cognitive dysfunction. So when you think about sleep, I often like to correlate that to what a personal trainer will do for your physical health. We need a lot of training, which means we need a lot of exposure to content and being cognitive functions, puzzles, work-related activities, anything that can really keep the brain activated. We also need proper nutrition. And we know that nourishment is important for our body, but it's also important for our brain. And we need proper rest. Same way that somebody that is always training for a marathon, they do not run nonstop. They have to have mandatory rest periods. Our brain needs rest, and rest comes in form of sleep often. There are also other types of rest. People could meditate. They could just have some quiet time. They could just relax their minds or lay down with their eyes closed. So different ways that you can rest, but sleep really serves a different purpose than just a typical rest of the brain. And a lot of aspects that go on probably relate to ATP production. So imagine during the daytime, your brain is very busy, it's breaking down energy. You really need to rebuild that energy during the night and during the sleep. And that's when a lot of that lymphatic clearance as well takes place, is also during the sleep. So in patients with HIV, which of the following has not been associated with poor sleep? A lower CD4 count, HIV disease progression, increased cardiovascular mortality, mood disturbance, or increased weight? So you may submit your answers. All right, good, excellent. You see, so this is kind of a tricky question, right? So poor sleep has actually been associated in some studies with lower CD4 count. It has been associated with worsening progression or faster progression of the HIV, has been associated with increased mortality, cardiovascular speaking, of course, mood disturbance, I think all of you know that, and has not been associated with increased weight. So the correct answer for this would be increased weight. And this is very interesting because the answers that we got really relate to the literature. There's very little that we know about sleep in people with HIV. And if you look in the literature, a lot of the studies are actually being underway recently. About 20 years ago, we worried about it, but I think the past 2 decades haven't been very rich in terms of data on this. So don't feel bad if there is knowledge in there that you don't know yet. I think there's a lot of knowledge to be gained. And at the end, I'll give you a list of some references. A lot of them really have just been published this year, and many of them as well are in the process of being published and research being sponsored as well. So what do we know in terms of prevalence is that over 70% of people living with HIV have described the sleep problems, which is over twice the rate of the general population. And the majority of them have insomnia. Now, there are, of course, many causes for insomnia, many more causes in people with HIV. But we know that if people have sleep problems, they have lower adherence of treatment, worse quality of life, worse metabolic control, and as well as depression. So it's very important for us. And I was very happy to see that many of you do discuss sleep, and you prompt patients also as well to describe how their sleep is during the visits. So today we'll focus on 3 main types of elements of sleep. Basically, I want you all to understand that in order to get good sleep, we need to have proper timing, we need to have proper duration and proper quality. Timing relates to the circadian rhythm, and I think this might be more of a topic that has been overlooked for many years. I've been working in the sleep science field over 20 years now, and to me that is always one of the top discussions in any presentation, because we discuss a lot of that in sleep science, but not in clinical practice. So when we look into the circadian rhythm, we have to remember that it is a self-sustained cycle that is synchronized to day and light exposure. And we do have specialized neurons that are now capturing the light information that comes through the eyes. So the retina is gathering this information and sending it through the tract out into the suprachiasmatic nuclei, where those neurons that are showed here in the fluorescence view are present. So those neurons now regulate their oscillations based on the light exposure or the absence of light. And that is very important, particularly now with modern life, that, we no longer have, dark hours in terms of low light hours. We have light presence in our daytime and our nighttime almost constantly. This is so important that the Nobel Prize of Medicine in 2017 was given to the circadian researchers, including our colleague at Rockefeller, that has been working in this field for many, many decades. So when we look into circadian rhythm, we can in a very simplified view, we can see there were 2 days that are displayed in here. You see this bout of sleepiness that comes in on the dark hours when the suprachiasmatic nuclei is not perceiving any light exposure. And then you have a quiet time, maybe a little bit of a bout in the sleepiness coming up after lunch. Now we do have a little bit of that. And then we'll have the second day again, mimicking that same shape. Now we have to be careful because we can't just easily shift all of this around, because our optimal performance will come on the opposite end of the sleepiness. So if the circadian rhythm kicks in a cycle of sleepiness certain hours of the day, we have to try to maintain that as regular as possible. And embedded into that sleep cycle, there are even different and more specialized chemical processes that we can see in here. So this chart is just showing us that cutoff of, let's say, the 8 hours or 7 hours, as long people might sleep, of sleep. And we can see that sleep is really not a stagnated process. It's very active. We go from different stages, from being awake into stage 1, which is considered a more superficial or transitional stage, then into stage 2 and 3 and 4. Academically, we don't call stage 4 anymore. We combine that into stage 3, and that's the same as delta sleep or slow wave sleep. And the reason for that is because if you see on the waveforms right in the middle, you can see that is really the waveforms which are reflecting the electrical activity of the brain is now slower and of a higher amplitude. And we know that children, or at younger ages, we have much higher amplitude. And as the brain ages, we don't generate such a high amplitude as well. So as we get older, we do not have as much slow wave sleep or delta sleep as when we are younger. But what is interesting is that even when we look into the graphic to your right, the slow wave sleep is not a continuous. You do go from different stages all the way into the deeper stage of sleep, the slower stage, and then you make your way back up. And that terminates with a cycle of REM sleep. So we call this one cycle of sleep. And normally at night, we have multiple cycles. In each cycle, let's say we have here 4 or 5 cycles on this graphic. Each cycle terminates with a longer period of REM sleep. So as the night progresses, we have more and more REM sleep and less slow wave sleep. There are several hormonal factors that help us regulate that function. And that's why sometimes people would say, well, if you're skipping your first 2 to 3 hours of sleep, when you fall asleep, you might not get the delta sleep that you normally get, because now you're pushing your schedule to a later time. So physiologically, you might have missed that window. At the same time, there are sleep disorders that can come out of those stages of sleep. We have sleep disorders that we call parasomnias, which are behavioral manifestations that happen from sleep. We inappropriately talk or walk, or we move a lot in bed, or we act out our dreams. So all of those behaviors may come out of the different stages of sleep. The delta sleep, which is called the non-REM parasomnias, are the parasomnias that we mentioned that often come in children: sleep talking, sleepwalking, night terrors, the more benign parasomnias. even if sleepwalking is, of course, dangerous, safety precautions are always very much recommended for patients. When people start acting out dreams, that typically comes out of REM sleep. So that's a REM sleep disturbance, and sometimes is associated with neurodegenerative disease, but not always. In a group of population that takes a lot of medications that may affect REM sleep regulation, sometimes medications could actually be the culprit for acting out dreams or having a REM behavioral disorder, as it is officially called. So the importance of looking into this is for us to perceive that sleep is actually quite complex. We're visualizing electrical activity, which is then indicating neurochemical changes. So different parts of the brain, different neural networks are activated in a process that allows us to sleep well. So it's a very complex phenomenon. And sometimes it's very hard for us, or always probably, to reproduce that artificially. So when we talk about improving sleep, this is the main reason why we always want to focus on behavioral approaches to restore your natural sleep or a patient's natural sleep, because it will be very difficult with pharmacotherapy to reproduce a proper night of sleep. And we should also remember, this is a chart that actually we had done at an elementary school presentation, which is now, of course, sleep is also important for kids. And I always love to show, because it was, them helping us draw this, which are the changes of body temperature that happen during the sleep. So we can see that our body temperature reaches its nadir just before we wake up, is the lowest point in our body temperature, starts to raise up as we wake up. And that correlates with a peak in cortisol, which we see on this blue bar in here. We also see now melatonin that increases at night, and melatonin is a dark signaling hormone as well. It can be very well suppressed by light, so we have to be very careful with light exposure at night, because it can dampen the melatonin production. And we also have a growth hormone peak that happens on the first third of the night, more or less related to that slow wave sleep period that we saw on the previous chart. So this is a cycle that almost perpetuates itself, and it goes back into that circadian rhythm regulation. Circadian rhythm is not just about sleep. It's about all the other processes that some of them are exemplified here, that are in combination, tightly regulated. And that's why people have jet lag, for instance. It's just because now you're not sleeping, you're not eating, you're not getting light exposure in the typical time of the day. So all your hormonal regulation will be off, gastrointestinal system function, mood regulation, and all of that will be affected. So some of the challenges that we have is how to really keep a regular schedule. And again, we're talking about the timing of sleep. So I often recommend, and I create this, patients can use different charts. Just try to log on and understand what time do they get up, what time do they go to sleep. And if once we visualize, sometimes it's much easier for us to try to help patients. Because if a patient comes to you and says, this is my schedule, and they can again write it down using numbers, or I like this, visualizing it this way, but whichever way works for them, this can serve as a great, very quick actually teaching tool. Because if they are complaining of sleep difficulties and their schedule more or less looks like this, then we can say, well, let's just figure out why you're going to bed at different times, why you're waking up at different times, why do you have a gap in the middle of the night? Sometimes people turn on that electronic device in bed and they have that flashlight coming into their eyes, and they are maybe playing a game or sending messages or working. Other times they don't wake up as much, as we see on the bottom, in the middle of the night, but they really have difficulty keeping a tight schedule. They go to bed at different times, and then they overcompensate by sleeping in on the weekends. And that's often a question we get from people, is it okay to sleep in and catch up on the weekends? It depends, because it depends how much you're catching up on your sleep. Is this affecting your circadian regulation? Is this affecting your ability to fall asleep on Sunday night? And a lot of those challenges are a little more present now that people are working from home and they have, different schedules. Commuting times are not necessarily the same, or not as important, or not important at all, if they have more flexible schedule. But the body was not made to have a flexible sleep schedule. So that's something very important for us to always discuss with patients. Now, the second part to go into duration of sleep, right? So that we spoke of now was mostly about timing. So looking into duration of sleep, just as a regular poll, there's no right or wrong answer here, but just to understand as a group, how much sleep do you typically have during the week? So not on weekends, less than 6 hours, 6 to 7, 7 to 8, 8 to 9, or more than 9 hours per night. So let's see if we're able to see the answers. I'm not, oh, good, excellent. Yeah, so I think we can see 44% are 6 to 7 hours, 38% 7 to 8 hours, 7% 8 to 9, 10% less than 6, and 2% more than 9. So this is a very typical distribution. It's almost like a Gaussian shape of a normal distribution. And we do see that most adults do sleep between 6 and 9 hours. So almost every answer will be okay. I think we have 12% of the group, 2% that sleep a little more than 9, and 10 that sleep less than 6. So I think that sleep deprivation of sleeping less than 6 hours will be something important for us to consider. When we look into data of people that sleep less than 7 hours in the US, you can see in this graphic, the darker areas are the higher percentage of patients or population that sleeps less than 7 hours. And it's very interesting to see that it's not an even distribution. So when people say, oh, this is all genetics, yes, there's definitely a genetic component. When we do see people that predominantly living on the eastern border of the United States, they tend to sleep less. So that probably implies a different lifestyle, different work schedule, different commitment levels with other, overscheduling of activities. So it's something important for us to recognize that, it's not just an even process, that oftentimes it is self-imposed, not necessarily in a great way. Sometimes there is a necessity for that, but it's important for us to keep that in mind. Because individual variations will tell us that, yes, some people need less than 6 hours, some people need more than 10. But many people induce that schedule. Of course, you can't sleep more than what you need. Sometimes sleeping longer hours could be associated with depression. So that's also important to know, or other health issues. People that are sicker tend to sleep longer. And when we look at charts of mortality, people on both extremes tend to have lower survival rates in the general population. We do not have specific data to HIV on this yet, but I think we will have that in the future. So this chart is just telling us the recommended duration again for older adults, maybe 5 to 9 hours. We might sleep a little bit less as we get older. It's not necessarily always true, but only 1 in 1,000 people can function effectively on 6 or fewer hours of sleep. And those are people that are genetically predisposed to sleeping less. But we can see that the 10% of our group is not alone. Over 70 million adults in the US sleep less than 6 hours. And our concerns about shortage of sleep is that it can be a cognitive impact. Those charts are looking at PET scans, looking at different areas of the brain being activated in a resting state. So this is a brain that rested the night before on top. Now on this bottom, we see a brain that is under sleep deprivation that did not sleep the night before. So we can see the significant decrease in brain activation after a night of sleep loss. And the same is true when we ask people to fill cognitive charts. So this is just different tasks for cognitive function monitoring. And we can see that on the battery of tests, people we call here fatigue, or people that miss 1 night of sleep, are very similar in terms of performance levels to people that have a blood alcohol level at 0.05%. So at the same time that we would not allow people to come to work intoxicated with alcohol, we should be very careful not to allowing people to get sleep deprived. And when we look into improving our own health and the health of our patients, we always advise people regarding alcohol consumption. We should always be advising them about avoiding sleep deprivation as well. And a big stealer of sleep is really our new technology, which has been amazing. It has allowed us to do sessions like this, to have a webinar where people can remotely connect from whichever location you may be. So whatever time zone you're at, I hope this is not the middle of the night for you. And here we can see, for instance, this patient using an iPad. She's not a patient, I'm sorry, it's the person on the public line. It's so interesting to see the amount of light that shines on this person's face, right? It's almost, again, if you had your personal flashlight at night. So this is definitely a problem, because now we're going to look into the circadian sensitivity. If you look at the spectrum of light, if you break down the spectrum into all the different wavelengths, we can see the circadian sensitivity on this dashed line is much stronger on this bluish to light spectrum, like 400 to about 500, 550 nanometers. So that's the visible blue and green spectrum of light. And that's why we always talk about blue light, because what happens is that a lot of the blue light LEDs that we have are really, as we saw in that picture, emitting light that is almost matching our eye sensitivity for detecting light. And that's the information that precisely informs the circadian sensors. So that can really affect our ability to sleep well and to metabolize and generate all the neurochemicals that are needed for sleep. So often we recommend blocking that, and there are ways of blocking. So this is just one example. There are blue light blockers similar to this. They have orange lenses, and they can actually attenuate, maybe not 100%, but they can attenuate the light on that spectrum. Of course, you're going to see a different light scheme when you wear those glasses, because it would decrease all the bluish and some of that sharp green color. But it can allow your circadian cells to be less affected by the light. Avoidance is always the best approach, but if you can't avoid, you could attenuate. Also, noise, temperature, and of course, comfort, if people are uncomfortable, are very important key items in the environment. So that's always a very important conversation as well with patients, to understand where do they live, what is their home situation, what is the bedroom situation, do they live in a crowded, warm, or congested with lights and noisy environment. I practice in New York City, so for us, this is always a very important issue. So the suprachiasmatic nuclei has this connection with the retinal hypothalamic tract, taking the information from the retina in terms of light. We have to keep in mind that even as we spoke about the light spectrum sensitivity, also the intensity of light is important. Even at very low light levels, so let's say 2500 lux is a low amount of light, even that can be enough to activate the suprachiasmatic nuclei and determine that this is more like a daytime exposure. So the light that we have exposed into the evenings, here put in this blue arrow, will shift your schedule to a later time. If we have a lot of light exposure in the morning, we'll do right the opposite. We'll shift that into an earlier time, which we call that a more advanced schedule. Sometimes we do both, and that's the problem, because when patients do both, they narrow their ability to sleep, just because you're having a lot of light exposure at night and you have to get going and have light exposure in the morning. So that will cause some sleep restriction and sleep deprivation. In terms of the effect of light in the circadian cells, it is much worse when it's given at the temperature nadir. And remember, that's about that 2 or 3 hours before waking up. So we have to be careful to avoid that. Jet lag situations are the ones that are a much higher risk for this. But we can also use lights intentionally to treat depression, let's say, and that's why often we treat that. But too much light can also lead to hypomania and, of course, a headache and other neurological issues. And it's not just about us and our environment or our patients in their bedrooms. We can see this picture from NASA is so beautifully shaped in the entire planet. You can see all the land areas and all the busy cities being so nicely lit at night. And this may sound beautiful, but of course it affects not just us, but nature as well, and other animals that are in the wilderness. And here we can see, we can map in New York City and other, like in Chicago, as just having those white dots on the map with so much environmental light. And depending where you are, this is my neighborhood. I work next to this building on the left. I live next to this building on the right. So we can see all the light that is emitted by people's bedrooms. So sometimes even their own choice of what type of lamp. Do they have a more warm lamp? Do they have a very sharp blue light type of emitting luminosity in the bedrooms or living rooms? This person to the right on that very sharp and blue light coming through, unfortunately, is across my bedroom. So when I moved to this location, my first step was really to find very good blackouts, because that's very important at night to try to mimic and restrict our exposure to light. So now we move on into the next aspect, which is the quality of our sleep and quality of sleep of our patients. Sleep disorders are quite prevalent, and it's interesting that, again, we do not have a very precise data in the population with HIV, but we do know that insomnia is quite prevalent in the general population, 25 to 30%. But in patients with HIV, it's probably over 50%. So some reports said 70 or 80%. Those are small sample sizes. So I decided to create this chart, plotting it at about 60, but there's really no true accurate data yet. Looking into this, some of the larger population studies seem to fall into that 58, 62% range. Sleep apnea is also very prevalent in the general population. Very prevalent in men, more so than in women. Women after menopause may develop sleep apnea as well. And in the HIV population, it's still unclear what is the true prevalence of sleep apnea. There were some older reports that had much higher prevalences than the latest reports, when medications for treating HIV were associated with lipodystrophy and changes in the airway. So that prevalence probably was spuriously elevated because of those medications in the past. So I think the jury is still out what the true prevalence. So that's why I put a very light blue in here. And also restless legs or movements at night. Restless legs is a condition where there are movements or uncomfortable sensation in the legs before falling asleep. When they persist into sleep, we call periodic limb movement disorder. It's basically a very similar condition. About 80% of people have both. Now, what happens with the periodic limb movement disorders is that it can really fragment your sleep and affect patient sleep quality. Restless legs can sometimes affect our ability to fall asleep. Now, in the population with HIV, we don't really know, very precisely what the true prevalence is, but there's some very nice studies that have been looking at smaller population. They feel that about 30% of patients, which is higher than the general population, have periodic leg movements or restless legs at night. It's unclear the reason for that. It could be related to medications, because some medications can induce, many antidepressants can also cause restless legs or periodic leg movements during sleep. So our discussion now will focus a little more on insomnia and sleep apnea. And of course, given COVID, we have to also keep in mind that COVID has caused a lot of disarray in most people's sleep. Of course, worsening insomnia because of all the stress, circadian dysregulation, as we spoke before. Many people have developed snoring because they've gained weight. Has been a bit of a roller coaster with weight. Many people gain weight in the beginning, then they lost, and now they regained. Lots of anxiety and fear that, of course, will affect sleep, and stressors, finances, work, school. And some people have been suffering with post-COVID sleep issues as well, that are not fully well described. I think we're learning through this as we go on, but we have seen a lot of patients with post-COVID sleep abnormalities. So the first step on evaluating anyone with a sleep disorder that you suspect might have a sleep disorder is really the interview. And of course, we always learn this in medical school or nursing school when we learn how to practice and see patients. But I can't underscore this. It's very, very important, because as you speak with patients, they will give you cues for where the management strategy should be focused at. Their habits, their social behavior, medications that they take, underlying issues, health-wise. It's very important for us to take a little bit of time. And of course, This consumes time, so that's a challenge for any provider to evaluate sleep disorders. So I think at some point, people do get referred to specialists to just focus our discussion on sleep disorders. But having a high-level conversation of that, I think, can be very helpful to every patient. There are some questionnaires that can be used. Some questionnaires can be focused on sleepiness, like the Epworth questionnaire. There is also the Pittsburgh Sleep Quality Inventory. So that's another questionnaire that is available. Some questionnaires specifically for insomnia. Clinically, we tend not to use specific questionnaires. We use for insomnia research, but it's easy to ask. It's easy enough to ask a patient about their sleep if they have difficulty falling asleep, difficulty staying asleep, or waking up too early. So those are conversations that can be easily done during the visit. Depression is a little bit harder, so sometimes getting depression inventories, and I'm sure many of you have that as part of your practice in HIV anyways, because a lot of people with HIV do suffer from depression. That's really a huge comorbidity in terms of sleep disorders. And we also can use a sleep diary, which was similar to the chart I showed earlier, where we map out where people's sleep schedule sits at. Actigraphy can be used. Nowadays, a lot of the actigraphs are really the wearable devices that many of our patients use. The usefulness of that is just the fact that it can help map out their sleep diary almost, you know, where they are sleeping. The precision of the data is not 100%, so keep that in mind. We did a study validating several actigraphs in the market, and which was published in one of the engineering journals. And it was very interesting because there are different algorithms that sometimes the same company allows you to use. And the precision can really be affected. Let's say the sensitive mode of specific actigraph was worse than just the regular mode. So just keep that in mind. Again, it can allow you for more of a trend, but not a true accuracy into duration of sleep or staging of sleep. That is an even harder data point for any of the wearables to provide. And of course, an overnight sleep study will really be the best way to evaluate any sleep disturbance. So in the Epworth Sleepiness Scale is a questionnaire that has 8 questions. So I think if you don't mind just reading through those and determining where are you at, sitting and reading, what are your chances of dozing off or falling asleep among never, slight, moderate, or high. And of course, some of the questions don't apply to a few patients. So then the max score on this would be 24, but sometimes patients do not meet some of the requirements. So let's say if 2 questions don't apply, then we subtract that. We write, instead of saying, 3 or 6 out of 24, we say 6 out of 18, let's say. So looking to your own score, we can answer this poll now. So what is your chances of dosing? So let's see. And again, combine, you need to add up all the answers. And then we'll see if we can look at the poll results just to have an idea or where everyone is at. Let's see. Oh, it appeared and disappeared quickly. Okay, good. All right, so a few people at 0, which is fantastic. People are sleeping well. 44% also between 1 and 8, which is great. So we tend to use 8 as a cutoff. So let's say we have 51% of the population live on the lecture that has no issue with daytime sleepiness. And then the rest, which is almost like a half and a half, has some mild degree of sleepiness, that 9 to 15. When it gets above 16 or above, or really very close to 24, we really need to pay more attention, because that's the time where the brain can unintentionally fall asleep, and you can get into what we call micro sleep episodes. When you shift that, remember the electrical activity we saw earlier on, the different stages of sleep, where we could be in the middle of a conversation and a little part of the brain starts drifting off into sleep mode. And that can affect our reaction time and our responsiveness to the environment. So if you're driving a car, that's when people tend to doze off and fall asleep. So we have to be very careful with that. Patients that have the higher scores, let's say 21 to 24, we need to pay a little more attention into, could this be narcolepsy, which is another sleep disorder that we're not covering today, but is a disorder of sleepiness that people tend to have really extreme sleepiness. They tend to have the highest scores. Sometimes very severe sleep apnea can also have high scores. And of course, sleep deprivation at any level. So people have significant sleep deprivation, they could have very high scores as well. So we always have to pay a little more attention to this. So thank you for answering that. So we go back quickly just into the sleep diary. And I think this is also a little bit for us, right, as providers, as we had that questionnaire, and then for us to apply to our patients. The two arrows and the dash in here is just to remind you, a quick way to discuss this is to say, what time do you go to sleep? What time do you get up? How easy is it for you to fall asleep? Do you wake up in the middle of the night? Those 4 questions will get you a lot of information. And that will be very helpful because we'll be using that to determine treatment approaches. So the presentation of insomnia usually has one of those 3 features, either difficulty falling asleep, staying asleep, or waking up too early. Sometimes people have a combination of them. Other times they may just have unrefreshing sleep, which on and off is in and out of the insomnia category based on our academy discussions. But I think for general purposes, it's good to have that in here, because some people they have no problem falling asleep. They sleep through the night, they wake up, but they are exhausted. So those patients are either not sleeping long enough, or there is a sleep disturbance that is happening and they are not aware of. Sleep disturbances often lead to lack of awareness, not necessarily by intent. It's just almost like having high blood pressure or high cholesterol. You're not aware until we measure and determine what is happening. Are the legs movement? Is the breathing compromised during the night? So the awareness during sleep is not there. So patients tend not to be good reporters. So if they have someone that can provide a report, even if they don't believe, often they challenge the person that reports their sleep disturbances. It's important for us to know. So in terms of insomnia, stresses and worries, they can cause all kinds of sleep issues. So that's always something important for us to discuss with patients. Anxiety and depression as well can also cause difficulty falling asleep. A sign of early depression sometimes is people start waking up a little too early. So that's also important for us to hear. Inadequate sleep hygiene or habits. We spoke about light exposure a little bit. Mismatched bedtime goes back into the timing and the circadian rhythm for sleep. Environmental noise, light, and temperature. Food or medication side effects, that's an important one. We're going to talk a little bit more about this. And of course, underlying sleep disorders. So for the population with HIV, we have to keep in mind that medications can cause insomnia. So it's always important to determine the onset of insomnia and ask patients what was associated with this, what changed in your life, what changed in your health condition or medications or environment. Sometimes people move to a different town. Sometimes people are starting on a new medication, and that could be triggering insomnia. Some medications are stronger than others, so that's why I mentioned a few names in here. But that goes beyond medications for managing HIV. Many of the other medications, even antidepressants, can lead to insomnia. So it's never 100%. So some patients are more susceptible than others, but it's very important for us to keep that in mind. And the list goes on and on. This is just, a summary of some of the medications. There are more medications on this page, including medications that are there to treat cholesterol. And sometimes we are able to change the medication from taken at night to the morning, and that can attenuate insomnia. So other times we'll need to consider different medications if we know that that was the culprit. So specifically on people with HIV, I think we have to also look into, besides, I think the first bullet we discussed, stress, schedule, and medical issues. Pain, I think sometimes is a big issue for patients, so we need to discuss that. Pain can disrupt the sleep in all types, forms, and shapes. It can cause difficulty falling asleep, early awakening, fragmentation, unrefreshing sleep. Mood disturbances are very important. Cognitive loss as well, sometimes and people could be aware of that at some level, and that can generate more stress. And often they have fatigue, and sometimes it's hard for us to distinguish fatigue from sleepiness or sleep loss. So sometimes we might need to do specialized sleep studies to determine if the fatigue is related to a sleep disorder or not. Sometimes people can be very fatigued but not sleeping. So that is more of a tricky medical evaluation process that sometimes is hard for us to fully answer without the studies. And of course, we spoke about medication and underlying sleep disorders. So the step for managing insomnia should always consist of a behavioral approach, which is part of the discussions we're having, in a cognitive approach. You want them to learn and understand. So a lot of what I'm discussing with you all today, it would be wonderful if you spread that knowledge with your patients, because if we provide them with the proper tools to understand how sleep is, they would be able to fix a lot of that on their own time and understand the importance that a medication sometimes can serve as a patch, but it cannot really fix the underlying issue. And of course, pharmacotherapy medications can be very helpful, particularly in acute cases or cases that need some more immediate support, or that patients can grow frustrated with just doing behavioral approaches. So sometimes I use medications temporarily just to keep them involved into providing or making changes in the environment and their behavior. So some pieces of the cognitive behavioral therapy that are important for us to remember are sleep hygiene. It's not a very good name, hygiene. People say I have a good hygiene, but sleep hygiene really focus on the behavior that we have before going to sleep. Do you eat in bed? Do they work in bed now? I have patients calling me saying, I was sleeping very well before COVID, and now they are Zooming into their visit, and I see them sitting on their bed doing a Zoom visit. They say, oh no, I work out of my bedroom and I work from my bed all the time. So that type of behavior is definitely a problem. Also, cognitive behavioral therapy has a component of teaching relaxation techniques, which can be very important. Sometimes deep breathing exercise can be very important for patients to decrease the stress. And deep breathing and breath holds can increase the parasympathetic system, so creating a better balance for us to allow patients to fall asleep. So often I recommend those. Yoga meditation can be also very helpful in offsetting or attenuating the stress impact on your sleep. And Tai Chi has been also an amazing tool. It can help with movement, it can help with balance, it can help with sleep. So those are very important tools as well for us to consider, which are not necessarily part of the cognitive behavioral therapy, but as they are part of the relaxation therapy approach, it will be important for us to consider that in conjunction as well. And always discussing with the patients to see what they are more interested in proceeding with. Improving their wake sleep schedule, we spoke about, and exposure to light is very important. Exercise is critical as well. Make sure people don't exercise too late, because if you're exercising too late, it can affect our ability to fall asleep. There's too much energy, the body temperature is too warm. But if you exercise during the day, you can actually sleep better. I recently had a patient, and the major intervention was for him to go back and swim, as often as he could. And his sleep issues are now almost fully resolved. So exercise can be very important for managing insomnia. And cognitive behavioral therapy is very effective, of course, with no side effects. It can be difficult to apply, but it should always be considered as first line. So some keys of sleep hygiene, we spoke about spending too much time in bed, avoiding naps, staying active, avoid the stimulating agents, which could be chocolate, could be caffeine. A lot of people, again, indulging in those sometimes a little too late in the day. Late exercises. Make sure that you also have an early dinner, because if you eat too late, then spicy meals can affect our ability to sleep, or they can lead to reflux. Minimizing alcohol. Alcohol always has a negative effect in sleep, so there's no use of alcohol in terms of managing the sleep disturbances, because once it gets metabolized, it really fragments our sleep. So patients should always be aware of that, and particularly patients that take medications that can affect liver function. And of course, I keep on reinforcing the regularity of the schedule and the bedroom environment, which are part of the sleep hygiene. So data shows here we have two groups of people. On the darker gray, we can see patients that only have insomnia, and in the lighter gray, patients that have insomnia and a comorbidity with anxiety and depression. These are just general adults, not in people with HIV, but we can see the response rate to cognitive behavioral therapy has been very high in both groups, particularly when people have anxiety and depression. So I think this is an important, even if we don't have specific data on HIV, I think this is an important data point for us to remember, because anxiety and depression, as comorbidities are so commonly seen in people with HIV. So the cognitive behavioral therapy is going to be important to be applied. I also like to give you some information about insomnia, some aspects that can be helpful for you in dealing with patients. One is to understand this model by a late colleague of ours, Dr. Arthur Spillman. He published this in 1996, and it's just a theory that he has had for many years prior to that, and clinically super applicable. So that has the 3P phenomena. One, that everybody has a predisposition for insomnia. So everybody has a bit of a threshold. So now this threshold can be cut if there is a precipitating event, something happened, like COVID happened, or people have now a new diagnosis of HIV, or they start a new medication, or their life changes. So that can get them through the threshold. But over time, that initial insult will decrease. However, often people develop bad behaviors that perpetuate insomnia. So often when patients present, they present at a later stage where the precipitating factor already dissipated, but they have perpetuating behaviors that maintain insomnia. On that acute phase, when it's just more the precipitating factors, maybe medications could be very useful in order to attenuate this. And that's often why medications are often recommended for a few weeks, not necessarily as a lifelong approach. But of course, as they come in a different phase with chronic insomnia, you need to discuss the more perpetuating aspects. So in considering medication, often I recommend breaking it down on the types of insomnia that people are presenting. If it's more of a sleep onset, a short-acting agent that's quickly absorbed would probably be a best approach. Also consider restless legs or other conditions. Again, all the sleep hygiene items we spoke that can be delaying sleep onset. Sleep maintenance, you might want to consider medication with more intermediate effect duration, because if they just are short-acting and quickly metabolized, they may not be as effective. Patients that have more of an early morning awakening often is associated with anxiety and depression. So a more anxiolytic or mood-enhancing or sedating antidepressants may be a good way to go. In patients that have a circadian rhythm schedule abnormality, looking into light exposure, both morning and night, putting the night lights off and adding the lights in the morning to recreate the rhythm, and having melatonin can be an excellent approach, always associated with behavioral. Most of the pharmacotherapy used for insomnia relates to a mechanism of action like GABA receptors, different pentamers, some are 2-alpha, 2-beta, 1-gamma. They can have different combinations of receptors because we have different units and subunits. And that explains why they are not all the same. So sometimes you can say that one benzodiazepinic, let's say, has a different effect or more effective effect than, or more side effects than others. So when we look into the FDA-approved medications, it's sometimes shocking to many people to see this, because a lot of the medications used for insomnia have been used off-label over the years. In fact, when I started working in this field, the most commonly prescribed medication 25 years ago was an off-label medication, and that was really the most commonly prescribed. It has changed over time. So it's important for us to then consider, if you look into the different options of benzodiazepines, let's say, or the benzodiazepine receptor agonists, which often we call as hypnotics, to look into the difference on the promptness and how fast, the half-life of the medication, how fast does it get metabolized and how fast does it get to work, because that will determine the best application. Some are quickly metabolized and fast to act, and others can stay in your system for longer. Melatonin is a melatonin receptor agonist available in the US. Again, this is only in the United States. Europe and other countries have different medications approved. They have more melatonin receptor agonists actually also approved. We have an antihistaminic / TCA, which is doxepin, that has a new approval, relatively new approval for insomnia, and orexin antagonists, suvorexin and lemborexant, which had been approved, not too long ago. And if you look at the off-label, you're going to see a lot of medications that have been frequently used. I'm sure many of you probably have used that for patients. So it's important for us to watch, because that category of antidepressants or antipsychotics has a much higher risk for drug interactions with all the protease inhibitors on NNRTI or NRTIs for patients with HIV. And then we have over-the-counter anti-epileptic agents and herbals. So I'll just spend a couple minutes discussing that in a second. So data on insomnia and HIV for a short-term use. So there's one publication came out this year. I put a reference down there for you. Zaleplon, which is a short-acting hypnotic agent, also improved insomnia, but also improved depression and metabolomic profile in a small group of patients when used for 6 weeks. So that's also important to know, because it's a good effectiveness, again, in acute terms. Melatonin can be very helpful as well as an over-the-counter. We have to be careful on doses in order to shift the circadian rhythm. Melatonin has been proven to be very helpful at very low doses, lower than what most general pharmacies would have. So sometimes people may need to look for specific retailers to purchase those. And this chart is just showing a difference in some melatonins that might have a delayed absorption profile, which can be very helpful, because instead of having just a high peak of effect and then dissipating, it may allow patients that have sleep maintenance issues to sleep well. And of course, always being careful, what is the residual effect in the morning? Herbals also have been typically used by patients. There is a huge industry of herbals that patients can find on the shelves or even electronically on websites. Most of them work through the GABA receptors. Valerian root is a common one. We have to be careful because it can also be hepatotoxic, and that has been the major issue with most of the herbals. Passion flower can also be a sedative and anxiolytic. Kava root, often used in Hawaii, can also serve as a muscle relaxant. We have to be careful again with potential addiction and hepatotoxicity of kava. Chamomile is interesting because it can also be a muscle relaxant, but it can have some cross-reactivity with ragweed in terms of sensitivity. So now a longer question for you all as we wrap up this piece of insomnia. Let's see the correct statement. Insomnia always requires the use of pharmacotherapy. Over-the-counter supplements have not been associated with liver toxicity. Hypnotic medications are contraindicated in people with HIV, or antidepressants always lead to insomnia, or non-pharmacological treatment should always be considered when treating insomnia. Sure, you're all going to get this correct. So let's see the answers. Excellent. Great. Okay, so virtually everyone got this correct. So that's perfect. In hypnotic medications, for 2% that answered, they are not contraindicated with people with HIV. The study we just saw was Zaleplon, which is one of the hypnotic medications. There's not a hard contraindication. We have to be careful again with drug interactions, so we have to always keep that in mind, however. I'm sorry. So now we move on into the last piece, which will be a brief discussion over obstructive sleep apnea. Predominantly central sleep apnea, we'll show in one slide. It's really not a major feature of patients with HIV, as far as we know. So again, new studies are ongoing, and hopefully we're going to know more as time goes by. So snoring, daytime somnolence, waking up at night, gasping or choking, all of those are symptoms of apnea. And we can see briefly, this is an old study of someone being monitored. This is a public record, that we can see the chest and the abdomen that really go in different directions when breathing at night. So this is basically what it means that the airway is obstructed. So we monitored breathing using either a full overnight polysomnogram, which is a complicated name for an overnight sleep study attended in the sleep center, or a home sleep study, which is really a bit of a misnomer because it's really not a sleep test. Most of the time, this is just a respiratory monitor. So for a patient that only has concerns about sleep apnea, a home sleep study can be sufficient as long as there is a good technology being used. I prefer the technology that we show in here, where you have bands monitoring the effort on the chest and abdomen, and airflow being monitored by a cannula and a finger oximetry. So all those 4 signals, along with the equipment that will give us positional and activity monitoring data, that can be very reliable for a patient that has suspicion of sleep apnea. Someone has severe insomnia, they might not sleep, and we probably wouldn't know. So for those patients, we may even start with a home sleep study because sometimes the insurance requires that. But for patients that don't sleep well, an overnight attended polysonogram would be better, because here we see they also have all the EEG leads, and that can give us additional information on the brain activity and stages of sleep. We also have EMG monitors on arms and legs. Say people are acting out dreams, you want to evaluate for a REM behavioral disorder, that may be a good way of doing that. So this is mostly to illustrate what happens with apnea. So this is a 5-minute compressed record of a patient that came in for a polysonogram. The blue line is pointing out this flat line that lasts, the interval between the pink lines is half a minute, so 30 seconds. So you can see intervals that are lasting more than a minute without any breathing. So this is really a sign of an apnea, and we know it is obstructive because the blue and the red lines just above it are showing that the movement, and not only the movement, but they are moving in opposite directions, as we saw with that patient, that you make an effort and they go in a paradoxical motion. So this is what the obstructive sleep apnea would be, and the index would be the counting of all of those events divided by the amount of sleep people have. Sometimes you can have a report that shows you an oxygen desaturation index, and that's now just looking at the oxygen level exclusively, looking for a percentage of 3 or 4 percentage points to decline per hour of sleep, and that would be what we call an ODI. This is the difference between obstructive and central. So we can see in blue is the same as the airflow that is here in black on the bottom chart. So you do see pauses, but the effort is very different. The obstructive shows that the airway is occluded, and despite an effort, there's no airflow. Central apnea we're showing here is more of a flat line because there's really no effort. The squiggly lines that you see in red in here are from the rib signal that are actually detecting EKG. So that is just the heart beating that is just transmitting over to the signal. And to prove our case, we have a glottic sign, which is the last, just before the oximeter that we see on the chart, which is an esophageal pressure monitor. So it's just telling us there is really no effort being generated. We don't typically use that clinically. So when you look into severity of sleep apnea, we would have the AHI to look for. Home sleep test will call you an REI, because we decided to change the nomenclature to make sure that people understand that's really a portable testing. It's the correlate of AHI. You also want to look at oxygen desaturation index, time below 90, and what was the lowest saturation at night. Based on our data, we see that half of the patients have mild sleep apnea, and mild is when the index is between 5 and just below 15. Moderate is between 15, just below 30, and 30 is 30. Severe is over 30 events per hour. Always pay attention to body position. Sometimes that can be a treatment approach. The different stages of sleep. Sometimes people have sleep apnea only during REM sleep, and the level of hypoxemia. And just as a side note, obesity is a major overlapping diagnosis in the general population. Again, we don't have a lot of detailed data yet. We're working on that on patients that are living with HIV. We treat sleep apnea in the general population because we know that after untreated disease, 10, 15 years after the initial diagnosis, the survival rate is much lower for people with severe apnea, as we see in here with the AHI over 30. The treatment has to be individualized. CPAP is really not for everyone, but for people with that AHI over 30 is likely the best treatment approach. We also need to discuss weight management, ENT, oral surgery or oral appliances, and this new treatment, which is the hypoglossal nerve stimulator. CPAP options are nowadays much leaner and nicer to use. They have applications that the patients can download. They can have their own app and monitor their usage. So that also helps improve compliance because they understand what they need to do to improve that if there is a mask leak or a comfort issue. And we know that CPAP now improves all-cause mortality in the general population again, and this relates to compliance. So we can see, my apologies here, the people with the lower survival, and this is about 72 to 96 months after CPAP initiation, were the people that were using less than 1 hour per night in a sample. Data monitoring can be available to you as well if you are the one prescribing CPAP, or it allows two doctors often to be connected to the network. This is just showing in green on the bottom all the nights that a patient used, average over 6 hours per night. This is an example of someone that has 2 units. So you see some dates that are missing information. This is because the patient lives between 2 homes and has 2 CPAP machines, because it would be unusual for someone to be so compliant in a few nights and not compliant at all in others. And this will give you the residual index, which in this case is 5.3, just above the threshold of normal, which is 5. Some equipment also allows you to monitor oxygen, and here we can see an oxygen trace on an oximeter attached to a CPAP machine. So for CPAP management, this busy slide just wants to summarize some key items. It is a team approach and requires a lot of work because you need to work with the insurance even before ordering a sleep study. There is some documentation that needs to be in place about the suspicion of the disease, to select the appropriate study, make sure that they will cover the study, schedule a visit to review the results, and schedule follow-ups after initiation of CPAP to document the compliance and document clinical improvement, because some insurances, specifically Medicare, but other insurance can also do the same, they may remove the CPAP if people are not compliant at least for 4 hours over 70% of the nights during an initial compliance check. Alternatives could be oral appliances, could be positional restriction or belts, tongue retainers, which are new to the market, weight loss, of course, and the hypoglossal nerve stimulator. This is an old idea, over 20 years old. They had pacemakers, which are called neurostimulators, that will be sensing the information from the chest and providing an electrical stimulus to the distal area of the hypoglossal nerve. This was approved by the FDA under a separate company, and this is a treatment that is approved as a rescue for patients that have failed CPAP, and it can be very helpful in terms of improving their condition as well. This is a video just to show you more or less what will happen. There is a stimulator that will run through the tongue, and you're going to see that tongue motion. So that movement was because of the stimulator that was activated. So as our final question, which sleep disturbance is related to rapid eye movement? So I'm sure you all get that right as well. So let's see the poll. Very good. REM behavior disorder, night terrors, sleepwalking, sleep talking, they are all part of delta sleep, non-REM sleep. So they are not part of the REM sleep parasomnia, and REM behavioral disorder come usually out of REM sleep because of lack of muscle atonia, which is a marker of REM sleep. The brain is very, very active, but we have atonia, so you don't act out your dreams. And restless legs is during wakefulness. So that usually is present before people fall asleep. When it persists at night, we call periodic limb movement disorders. And then leaving you with some references, and we'll wrap up with the pretest question. So I won't repeat the questions. I'm sure you all will get this as a post-test. I'm sure you all get 100% on this. Let's see if they're going to show that. I'm not sure if they show that. And then post-test number 2. Perfect, 96%, correct, excellent. So the post-test question, oops, my apologies. Excellent, so we'll look at the poll results and then we'll move on to the Q&A. And I want to thank you all again for all your time and participation. It has been really a pleasure to speak with all of you remotely so today. Excellent, 93%, that's fantastic. So we're now going to the Q&A. So thank you for sending questions. Many patients taking medical marijuana, very good. I did not discuss medical marijuana because we really do not have a lot of scientific data. Some of them can improve sleep, but there's a lot of difficulty regulating what is the components and the compounds that are being used. There's cognitive concern though about chronic use of marijuana as well, so I'll just be attentive to that. Good, beautiful to see that as the HIV prevalence, that's great. You discussed depression as a potential cause of insomnia, cyclical relationship. Yes, it could be. Some people may have, people that may have seasonal affective disorder as well. But depression can really significantly come with insomnia, or sometimes it comes with excessive sleep duration, very long sleep duration, sometimes can be a feature of depression too. Now, patient on nightly lorazepam and alprazolam for years. Usually to wean them off, the first step I always recommend is just to try to look at all the other behavioral approaches, make sure that everything else is perfect in their sleep in terms of cognitive behavioral therapy, sleep hygiene, and then very, very gently trying to wean off the medications. Alprazolam tends to be the harder one to wean, so I would recommend actually starting with that and trying to do. Sometimes I do weaning. People may go to a low dose, or they shave off a little bit of the tablet, or they alternate nights. So we try to be very careful as we wean any benzodiazepines. CBD oil for sleep, I think is similar to the marijuana as it is skin. I think that that is fine. Some patients use CBD oil as well effectively for restless legs. Sometimes the application on the feet can be very helpful. Again, not a lot of data on this, but we have a lot of clinical anecdotes that people do very well on that. We just learned that hormones were in effect if they went through the stomach. How does melatonin get through the GI tract? So it depends on the formulation of GI, of melatonin. There are different components out there. There's one formulation, there are two significantly tested, clinically speaking, formulations that have very good absorption. And they use proprietary mechanisms, so sometimes we don't really know exactly what they use in order to stay intact as they go through the gut. And a final question on sleep disturbance associated with weight gain and obesity. Shed more light. Yeah, so it's not that it's necessarily the reverse to people with HIV, is that it hasn't been an association with sleep or insomnia, let's say, or sleep issues. The general population, yes, people hormonally are not well regulated if they don't sleep well. So that could be to weight gain. But it's a very complex phenomenon. It's not as streamlined or as straightforward as we once thought with leptin regulation or ghrelin regulation. People with HIV is also compounded by other issues that relate to fatigue or muscle wasting and the disease processes. So that's why it's not such a clean-cut relationship with weight and sleep. Dosing and time of melatonin, excellent question. I think dosing and time is important because I typically like to start with very low doses to avoid any residual effect in the morning. Sometimes melatonin could be taken at bedtime if the issue is more of a sleep fragmentation. If they have difficulty falling asleep, I would typically ask them to take 2 hours before the desired bedtime to see if that works. If you want to shift their sleep schedule, you may even need to take it 4 hours before the desired bedtime. But for typical insomnia, within the 2-hour frames. Sometimes people feel that the insomnia may be too strong and too sedating. And if that's the case, they can take it closer to bedtime. Sleep disorders in developing countries, yes, definitely underreported. Yes, I think, there's a lot of difference where you practice. I think the developing countries are now unfortunately being victimized with all the technology, which again is great. I can't speak fully about technology because it has helped us, survive a lot of things, but we have to be very careful on the appropriate use of technology. So I think in terms of behaviors, it should be something important to look into, to training people in developing countries to avoid overuse of technology at night. White noise, I'm glad you mentioned that. I had to remove that because we had too many slides, but white noise can be very helpful for sleep. So I think we test with patients. We did a study just recently published looking at white noise in people that live in noisy environments in New York City, predominantly people that live close to the airport, and white noise significantly improved their sleep. I have a patient using a full mask CPAP. It has a vent about 20 per night. I typically like nasal masks better. A full face mask, which means it covers the nose and the mouth, typically requires a higher pressure on the CPAP. So if the titration was done with a nasal mask, always keep that in mind. We also publish a lot on that field, showing that a different mask interface requires higher pressure. So consider that, or change back to a nasal mask, which sometimes is easier. The nasal masks nowadays are very small, easy to use, and very easy to maintain seal because it's a small surface area. Oh, that's now a tricky question. How long should people remain in mind if they're not falling asleep promptly? I typically don't like the recommendation to get people to get out of bed if they don't sleep, because it gets them to track time. What I typically like to do is just to shorten the time they spend in bed by putting them to bed a little bit later and getting them to wake up earlier. We call that sleep restriction. So that way we say, listen, okay, you're only going to spend 6 hours in bed, but now you're going to be able to sleep through. And then slowly we increase the amount of time people have in bed. Now, would someone need to start CPAP before BiPAP? BiPAP is given predominantly for people that have hypoventilation or any other disorders that require, besides the opening of the airway, ventilatory support. In the past, sometimes people were using BiPAP machines for people that failed CPAP. We don't typically recommend that because the new CPAP technology allows for a natural BiPAP-like fluctuation of pressures, which means allows for an expiratory relief. So when people start to exhale, the pressure can be decreased in the system. So that has improved phenomenally the tolerance to higher pressure of CPAP if need be. Very good. Thank you. Thank you so much for your questions, amazing questions and excellent interaction. Really has been my pleasure.
Thank you, Dr. Krieger. As a reminder, evaluations and how to claim continuing education credits will be emailed by 5 p.m. Pacific time tomorrow, and this will enable us to review all of those that have attended today's live broadcast. Here are a list of our upcoming webinars available for sign up. And next week, make sure not to miss our highly anticipated HIV 101 webinar. Here are a list of upcoming courses. And again, to register, please visit the IAS-USA website. The virtual Ryan White HIV/AIDS Program Clinical Conference will be held virtually from Sunday, October 3rd to Wednesday, October 6th. To view the online agenda, please visit the IAS-USA website. We will be adding a new dialogue to our website, and it'll be available for sign up sometime today, and that will be held on October 22nd. Again, we'd like to thank our presenter, Dr. Krieger, and this concludes today's webinar.